So I think Dr. Jitendra Anand and Dr. Devangsha is there. We can always start now. So I would like to request Dr.
Yes, sir.
Jitendra Anand, Dr. Devangsha, Dr. Ronak Shah, and Dr. Ronak Shah 1 and 2. Ronak has been always dynamic. So we have 2 Ronak Shah. So I will invite them as a moderator, and I would like to request Dr. Jitendra Bhai to introduce our chairpersons.
Thank you, sir. Now I would like to invite Dr. Gaurav Gandhi from Jamnagar, Dr. Sanjay Wagani from Surat, and Dr. Keval Kanabar from Ahmedabad as a chairperson for Bout 1. Please, sir. Dr. Gaurav Gandhi, sir.
I think we can't hear anyone.
Yeah. Hello. Sir, am I audible?
Yeah, now you are audible.
Kalpesh, am I audible?
Yes, sir, you are audible.
Yeah.
Yes, you are audible. Sir, please start.
Sure. Let me share my screen. Please allow me to share my screen.
Sir, now you can share your screen.
Yeah. Thank you so much. Yeah. So on behalf of organizing committee, I would like to welcome all delegates, faculty members, moderators, chairpersons. Coming to the topic, the thrombolysis with any novel lytic agent is best as time is muscle. The case is already discussed and open for all the audience. So I go directly. Goal for this patient, the timely reperfusion first, protection of the staff and organized use of resources and minimal adverse outcome. So my choice will, am I audible?
Yes, sir. Yes.
Yeah. So I would.
Yes, you are audible. Please go ahead, Mukesh.
Yeah. Okay, sir. So I would prefer thrombolysis for these patients and later on intervention when patient is COVID-19 free. The guideline, it says itself that when patient is having COVID with STEMI and for suspected and confirmed cases, that reperfusion depends on the hemodynamic stability. If patient is unstable, then the PCI is the option. And if patient is stable, as our patient is, she is hemodynamically stable, so thrombolysis is the best option. And in the first 3 years, the primary PCI and fibrinolysis both has been given a class 1A indication, means both are efficacious and effective. The point number 2 is time is muscle. We know that the maximum benefit which we can give to the patient in within 3 years, and among them, the first one is the golden hour for reperfusion therapy. So door to needle time can be achieved with fibrin specific agents because they can be given within seconds. So these are appropriate agents. As we know that door to needle time is directly related to the mortality. As time is less, mortality is less. So the point number 4 in favor of fibrinolysis is the total ischemic time that should be less than 120 minutes from the first medical contact. As we are living in the COVID pandemic, so we know that the delay can be because of the patients or medical staff if there is in lockdown situations or maybe prolonged emergency department evaluation that we know that patient has to undergo HRCT or biochemistry. And further, if cath lab is busy and my friend Dr. Kalpesh is doing some complex as he used to do, so there can be a chances of further delay in the cath lab itself. So there are several factors where we can increase in the total ischemic time. Coming to the efficacy and patency rate of the thrombolytic agents, we know that all the fibrin specific agents, they have 85% patency rate. So that increases overall, gives mortality benefit to these patients. The next point is the TIMI score, that we know that our patients related to the TIMI score 3, which is very mild, almost 4.4 mortality compared to the higher mortality where patients require primary PCI. So our patient is quite a reasonably good candidate for fibrinolysis. The next point, that we know that she is young female, and in the COVID setting, we know that the plaque rupture is the main mechanism which leads to thrombus formation and MI. And in particular, this setting, the thrombolytic is more efficacious or more effective agent. This is the paper from the JACC that we know that there is a greater plaque thrombus burden compared to the non-COVID patients in MI settings, which lead to more reflow, no reflow during the primary PCI, and the no reflow phenomena itself increase morbidity and mortality in these patients. This is the important point which I would like to take attention of my friend Kalpesh, that there is significant number of stent thrombosis, that is almost 4 times compared to the non-COVID patients, and which is really a dreaded thing when we do a primary PCI in COVID setting, when there is a lot of inflammatory marker raised, all these cascades, cytochrome storms, coagulation cascade, all these factors are responsible for this. Coming to the point number 10, that this is the paper from the Hubei, which is one of the epicenter in the pandemic area, where there is almost 40% increase in the fibrinolysis, and at the same time there is significant almost 40% decrease in the primary PCI, but the effective reperfusion remain equivalent in the both the group. So we can say that fibrinolysis is really a good choice. That fibrinolysis leads to reduction in ischemia time, earlier reperfusions, I would say higher TIMI3 flow, decreased clot burden, a lower incidence of no reflow phenomena. And same time, we have to conserve our resources, that if patient, because of the COVID patient, if our staff get infected, it means that staff has to quarantine for 14 days, and then we have to be short of staff with cath lab, and sometimes it's difficult to run primary angioplasty in these setup. The coming to the clinical trial, which favors that we show that changes in 30-day mortality according to the use and type of reperfusion therapy in fast MI trial, that shows that fibrinolysis is almost comparable with the primary PCI in terms of mortality. Even same the AMI trial that shows that the AMI trial, they also show that major bleeding was not significantly different between these two groups. The transfer AMI study, that is for the pharmacoinvasive therapy, that also shows that with after thrombolysis, if patients go for primary PCI, that reduces incidence of ischemic complication and almost similar bleeding. So we can say that pharmacoinvasive therapy after fibrinolysis is a reasonably good choice. The same, almost similar kind of study, or Minneapolis, that also shows that pharmacoinvasive therapies gives almost similar kind of results with compared to the primary PCI, like 30-day mortality, stroke, major bleeding, reinfarctions. This is the STREAM trial, that is also a major trial that for pharmacoinvasive therapy, when one arm is for the standard angiography followed by angioplasty, and one for fibrinolysis and followed by angioplasty pharmacoinvasive therapy, that shows almost similar results in terms of all-cause death, cardiac death, congestive heart failure, cardiogenic shock, and reinfarction. So my take home for this patient is that the fibrinolysis is suitable options for acute MI, as this required less time, less hospital resources, easy to administer, and equivalent outcome when it is given timely. And the resources management like cath lab staff and prevention of spreading of infection is crucial point to be considered at the time of treatment plan. Pharmacoinvasive strategy is recommended when and where primary PCI is not achievable within the recommended time frame. Thank you so much.
Chairpersons, please invite the speaker, chairpersons. Next speaker is Dr. Kalpesh Ansora. Birthday. So he's going to deliver a talk on his birthday.
Happy birthday, Kalpesh.
Thank you. Thank you.
Kalpesh is an interventional cardiologist and he's going to talk about primary PCI. Kalpesh, please go ahead. You can share your screen.
Yeah. Am I audible, sir?
Yes.
Yes, you are audible.
Okay. Visible? Screen is visible?
No, no, skin is not visible, Kalpesh.
So I'm not able to share my screen.
Hello.
Hello, I'm not getting option of sharing.
Yes. First of all, sir, open your PowerPoint.
It's open already.
Okay. Zoom स्क्रीन पे अभी सर आपको शेयर स्क्रीन का बटन दिख रहा है ग्रीन आइकन.
Yes.
उस पे क्लिक कीजिए सर.
नीरम आलेक्स इवेंट आ रहा है उसमें.
हेलो.
हेलो.
यस सर, वो आपका स्क्रीन मिनिमाइज हो गया मैक्स.
Now visible? Okay. No, in between it's going up.
Done, sir.
Visible?
Yes, sir. Yes.
Yeah, please go ahead, Kalpesh.
So my colleague friends has already discussed about the advantages of fibrinolytic therapy in this patient. So it's 45 years female with anterior MI. And I think Suresh just missed actually patient is reached to the COVID capable and unable to hospital where the 24 hours cath lab is available and cardiologist is also available. So I'm not going to detail in this case as Mukesh sir has described. This is also described by Mukesh sir. The time is muscle. In a heart attack, every second counts. And selection of perfusion strategy, which involves the assessment of the time from onset of symptoms, which is 3 years here, is COVID-19 pandemic scenario. And we have to see the risk of SAMI. Patient, he is having an extensive anterior LMI with Calypso class 2. Of course, same time, we have to see the risk of bleeding if we are selecting from the thrombolytic therapy. Total ischemic time, as already Suresh mentioned, that can be maximum delay up to the 120 minutes can be acceptable in this scenario, and time required for transport to a skilled PCI and dedicated COVID cath lab is also important. What sir has not mentioned, that guideline of the primary PCI and fibrinolysis by the European Society of Cardiology, that primary PCI remains the reperfusion therapy of choice if feasible within this time frame and performed in the facility approved for treatment of COVID-19 patient in a safe manner for healthcare providers and other patients. So still guideline recommended that if patient is reached to the hospital where 24/7 cath lab, which is COVID enabled center, if it is available, then the STEMI patients should go the primary PCI first. Suppose if patient is transferred to the non-COVID hospital where the COVID hospital, but there is no cath lab facility, then still patients if can reach up to the primary PCI capable hospital, still primary PCI is the first option. If it is not possible to transfer the patient within the time limits, then fibrinolysis is a choice of therapy for the reperfusion in these patients. The primary PCI goals already has discussed the goals of reperfusion therapy. I will not go will go to in the details. Primary PCI is the most promising gold standard approach for STEMI care. And there is a selective primary PCI recommended in the large anterior wall MI. The case is here is large anterior wall MI. Other indication is cardiogenic shock, hemodynamically unstable patients in setting of ventricular arrhythmia, and there are no contraindication to the thrombolytic therapy. And the maximum time delay from STEMI diagnosis to reperfusion of 120 minutes should be remain goal for the reperfusion therapy under following consideration. And this primary pathway can be delayed during the pandemic up to the 60 minutes according to the multiple experience due to delay in the delivery of care and implementation of the protective measures. Now, if you see what are the advantages of the primary PCI in patients who is presenting with large anterior wall MI and in current situation of COVID-19 scenario, if you perform the primary PCI, the attainment of the TIMI-3 flow is much more common with primary PCI. So this is almost 93 to 96% in PAMI patients, and it is studies in Cadillac trial. And patency can be defined as the antegrade flow through the site of obstruction is restored in 87% of infarct-related artery, while normalization of blood flow, which can be assessed by TIMI grade, it is occurs only 50 to 60% cases of thrombolytic therapy. So this can be result in the prolonged ICU hospitalization, and it associated with exposure to multiple healthcare provider and limiting the access of ICU beds for COVID patients. And furthermore, after fibrinolysis therapy is 50% of patients which may require the rescue PCI. And if you see the effect of time to treatment of reperfusion rate with thrombolytic therapy, the TIMI flow rate, which is achieved in this TIMI-1 trial, Ghost's trial, RAPID-1 and RAPID-2 trial, is quite higher if this performed within the time of window period. Now, this is a slide of the coronary angiography, and if you see the first patient who had a large anterior wall MI, he had a occlusion of the LAD proximal artery, and after PCI there is a beautiful flow distal vessel which you can see in a frame after primary PCI, while compared to the patient who had a thrombolysis therapy in a PCI, there is a large residual defect which is showing visible thrombus even after thrombolysis therapy. Now, if you compare the bleeding risk in patients with the primary PCI versus thrombolysis, bleeding is more commonly seen in thrombolytic patients. Hemorrhage is another important issue with thrombolytic therapy. Intracranial bleach, which is up to 1% of total population, has been studied, and major non-cerebral bleeds occurring 4 to 13% of patients treated with the thrombolytic therapy. Come to the reinfarction rate and recurrent ischemia. The following thrombolytic therapies, there is a prothrombotic period, of course, as Sir has mentioned. The occlusion rate of the infarcted related artery may be high as 10% in hospital and up to 30% by the 3 months. And reinfarction rate have been reported to be around 5% in hospital and 7% within the first year of thrombolysis. So quite high reinfarction, recurrent ischemia in thrombolysis therapy. And we know that the multiple contraindications which are required to assess before the starting thrombolysis therapy, but specifically you can see that in COVID-19 patient who is infected, there is a more risk of cytokine storm. If patient having a cytokine storm, if you thrombolyze the patient, there is a high risk of bleeding And if you see the long-term outcome with primary PCI compared to fibrinolysis, this is a dynamic 2 trial. They have studied the cumulative events, the cause of 16 years outcome, and composite endpoint was all-cause death, rehospitalization of MI, and for MI, they have compared, and they have shown that the benefit of primary PCI over the fibrinolysis was maintained at the 16-year follow-up, and primary PCI reduced the composite endpoint of death, rehospitalization for myocardial infarction, reduced cardiac mortality, and delayed average time to a main event by approximately 1 year. Now, if you see the what are the benefits of primary PCI in this patient, there is the higher rates of infarct hereditary artery patency, TIMI-3 flow, lower rates of recurrent ischemia, infarction, emergency, repeat revascularization procedure, less risk of intracranial hemorrhage. There is always mortality benefit with the primary PCI, less hospital stay of the patient, and more effective. In COVID-19 pandemic situation, hospital stay also matters. What are the pitfalls of fibrinolysis? There is the multiple contraindications, multiple complications, less effectiveness. Even after successful thrombolysis, patient may need for the coronary interventions. So in primary PCI, risk is exposure to SAF, of course, delay in procedure due to primary protection exposure and COVID-19 testing required. But benefit, already we have shown that what are the benefit of primary PCI. The additional advantage, there is a mimics of the STEMI in COVID-19, like myocarditis, that you can detect during the primary PCI. That and thrombolysis risk, we know that the length of stay and use of resources will increase. There is a risk of hemorrhagic stroke, and alveolar hemorrhage is also high, and treatment in condition like mimicking SCS. The benefit is there is a less exposure to start. The recent study showed that 31% of symptomatic patients with COVID-19 can go into the acute respiratory distress syndrome, and there is a increased risk of alveolar hemorrhage with thrombolytics if you use the thrombolytic section. This is a good point. With here patients COVID-19 infection with almost 12 score out of 25. So it's quite high risk for the developing of acute respiratory distress syndrome, and that will be ultimately end up into the alveolar hemorrhage if you thrombolyze. Not only that, the thrombolysis also increase the utilization of resources because increased length of stay and complication arising from the thrombolysis. This is one analysis was published in a Wuhan study that almost 29,000 patients were almost from the 229 hospitals. That was the CAD database study, that in hospital mortality, length of stay, and length of stay more than 4 days was quite significantly higher in group who has received the thrombolysis therapy. Of course, there are lots of challenges in performing the primary PCI. There is a significant risk of nosocomial spread of the virus, endangering the hospital life. There is a delays in patients' transport to hospital, prolonged emergency department evaluation, delays in emergency medical system availability, and transfer times, well sanitized and well equipped catheters, which must require for the treating the COVID-19 infection. And of course, there is a decrease.
Sir, your time is up, sir.
Surely. So delay in door to balloon time. So I think this, if you consider patient is reached to the COVID-19 enabled cath lab, I think then primary PCI is the best option for these patients. Thank you.
Chair, please invite the final hour speaker, Dr. V.C. Chauhan. Chairperson, please.
Am I audible?
Yes, you are. Yes, you are. Please go ahead.
I'd like to invite Dr. V.C. Chauhan, MBBS, MD Medicine, and Fellowship in Interventional Cardiology. He is one of the first men in Gujarat to start invasive cardiology after training from St. Vincent's Hospital, Melbourne, Australia, and now having own consultation clinic and visiting to DAGH, Vadodara. I would like to invite you, sir.
Yeah. Kamal, should I start sharing? Because
Yeah, please share your slides.
please go
Please,
ahead.
I can't hear actually.
yeah, please go ahead.
Sir, you can start.
But there's something different. Can you see my things? Can you see can you see the screen or not?
Sir, I can see your screen.
Hmm.
Put it on slides or more.
Yeah, so can you see it now?
Yes, you are visible.
Sir.
Please go ahead with the next slide, please. Yes, we can see.
Yeah. So basically, first I'm wondering why Kamal invited me for this particular debate, because both of the people, one is thrombolysis, one is PCI, both gave enough justice. So initially I thought I had to talk in favor of thrombolysis, but later on it is not thrombolysis. It is one particular agents compared to other agents. So I was a little confused. Anyway, Mukesh Ladda has done Ladai very well, and he has done a lot of points in favor of TPA. On the other hand, I am the one who is interventional cardiologist like Kamal Sharma, and to talk is different, to do is different. So first I will have my, sorry, this is always a problem. My disclosure that I am not a politician. So I'll try to tell the truth without trying to win the debate, because there are many points that is against what I'm going to talk myself. And unlike politician, I would like to be balanced. So there are some points that I want to talk in favor of thrombolysis as well, some point in favor of intervention as well. But my topic today is more on talk about thrombolysis in corona period and which thrombolysis to be given. Now, before that, let me tell you there's a very close relation between corona and coronary. And the people like us who are cardiologists think that we control coronary arteries, but that is not wrong. That's absolutely wrong. It is illusion that we control coronary arteries. This is whatever treatment we have. Same as illusion the other people have. So coronary disease is definitely number one mortality. And unfortunately, corona is number two at the moment in US. And this is our patient, which is 45-year-old female who has anterior MI and fever for last 5 days. So see, we had all the protocols where if patient is suspected corona, we do this thing. Here we are talking of patient who is an acute infection, who is only 5 days old, during which chances of infection spreading to others is extremely high. So we are dealing in very different situation where probably corona itself requires equal treatment attention as the coronary artery disease itself. As it is said, CORAD score is 5 or CT score is 12/25. That means if the patient has very high chances of succumbing to corona itself, we have to pay equal attention to corona as well. So here just I have mentioned that young age, rate things like 45 years of age, acute fever with ongoing fever, 5 days history, CORAD 5 score, positive RT-PCR for corona, window period is less than 3 hours. All these are the point which favors thrombolysis. On the other hand, anterior MI and COVID enable cath lab that favors PCI. So both, we have points in favor of both, but my topic is which agent to be considered in case we think of thrombolytic treatment. So obviously, as everyone has very previously said, the time is the muscles, and that makes a lot of difference. As you can see, as the time passes, more and muscles get damaged, and that becomes more irreversible damage. So I put this slide to explain the lay people. None of you are lay people, but just to explain the lay people that how time is important, I tell them that if there's a fire within the house, earlier you control, lesser is the long-term damage, because whatever become ash cannot be recovered. That is, so we tell them, you try to get whatever treatment is available. Don't try to get the world's best fire brigade. Use local resources. That is what is happening in coronary artery disease. If you are in a setup where corona-enabled cath lab is not available, immediately give thrombolysis. If it is available, but Kamal Sharma has 10 cases lined up and he said, no, he won't allow you to enter, then you have to give thrombolysis. So it depends upon which cath lab you are and what is possibility of doing angioplasty within time. In corona period, we have seen that whatever you say, it always takes 1 or 2 hours of delay. And there are so many protocols, like our hospital, we cannot put patient in ICU unless you have done RT-PCR as well as HRCT of the patient. So if HRCT is strongly positive like this, you have to put patient in a corona ICU. And that increases their cost so much that many patients are not ready. So many patients are not ready to take risk of angioplasty and corona ICU both together, and you have to think of thrombolytic treatment. So as you say, the time is muscle. Whichever treatment you can give very fast is the treatment of choice in this situation. That has been very well mentioned by Mukesh Ladda in previous slides, so I will not go it. And here you can say in this particular patient, if patient has come within 3 hours, it's obviously both the treatment are equally important. But as it is mentioned that if patient is not ready for PCI or PCI cannot be done within 120 minutes, then only we should consider thrombolytic as a treatment of choice. Now, in this particular patient, we don't know what was the choice of patient, choice of relatives, so we have no idea which would be better in that case. But in general, this guideline shows that if it is not possible to angioplasty within 120 minutes, you have to consider thrombolysis, which is given by lytic bolus rather than infusion. So what I want to mention is you have to select the thrombolytic agent which can be given very fast. If you can open the artery within, let us say 20 to 30 minutes after thrombolysis, it could be as effective as angioplasty in the first few hours, because even if the patient comes on the door on the cath lab within 20 minutes or 30 minutes in PCI enabled center, I have seen many patients there because of slow flow, because of resource problems, you are not able to open the artery within a very short time. Sometimes in a young people with a lot of thrombotic burdens, even if you open the artery, if the STEMI through no established, you cannot put stent in and that artery doesn't remain open. So there are many patients where we regretted actually by taking patient into cath lab, especially young people with a lot of thrombotic burden. So it is not that angioplasty is always better. You have to individualize the situation. And in COVID era especially, we have seen so many papers like in circulation, the value of proposition of thrombolytic therapy or pharmaco-invasive therapy. This is, as for example, one idea which we actually, when we want to do angioplasty, we never look at this type of slides. But this indicates that if you say primary endpoint, death, intracranial hemorrhage, maybe other than intracranial hemorrhage, in all other things, both the therapy, pharmaco-invasive or PPCI, almost equal. So when we want to try to save one patient, and if you have another option which is equally effective, you must take the option which is safer for us. So suppose you save the patient by primary PCI and give 5% benefit, but one of your staff is involved, probably you are at much risk and much loss. So I would not consider angioplasty as the first choice in that situation. So when there's an unprecedented pandemic like this, you have to take care into account health system and what is the safety of healthcare professionals. So if you can give thrombolytic therapy very fast, probably that is what is most important therapy. And that is what we say. So in this situation, our patient belongs to this category. He has a ST segment elevation MI, but there is severe pneumonia. So probably this is a situation where conservative therapy, including fibrinolytic therapy, is preferred option. So that is what we have to follow in this particular patient, thrombolytic therapy. Again, if you go into the guidelines, this is a patient who is confirmed COVID patient, not only confirmed, fresh confirmed COVID patient with pneumonia. So probably belongs to group A or B, probably group A. And that is why thrombolytic therapy is prudent option in this situation. That is what we have to consider. Among the fibrinolytic agent, we have 4 agents that everyone knows. So many of you are doing what is known as myogena patient. In that case, if you have to do thrombolysis, streptokinase is the only option, no argument. But if patient is probably affording, then which agent should be used? So here I will just like to say plus minus point of each of the agents and then tell which is the best agent. Obviously, the thrombolytics therapy, you have to compare with the PPCI. It has to act rapidly like convulsion. It should be act very fast. It should be very efficacious. Within 60 to 90 minutes, vessels should be open. Low side effects, low reocclusion rate, very easy to administer. So obviously, bolus is always easy, especially in corona positive patient. We don't want to do infusion or two bolus, etc., etc. There should be patient tolerant dose, means patient's weight accordingly we can decide the dose. If there is a different dose schedules, we can reduce some of the side effects or we can increase some of the efficacy, and should have equally good long-term outcome and should be cost effective. So out of this, we have 2 major groups. One is fibrin non-specific like streptokinase. Another group is fibrin specific. The other 3 agents that we mentioned are fibrin specific. So here clearly, if you use streptokinase, there is more allergy, less efficacy, more bleeding because it acts everywhere. While fibrin specific has less chance of bleeding compared to streptokinase, less chance of allergic reactions because it's a fibrin specific. So it acts only at particular levels where we have the fibrin clot formation into the coronary arteries or some other place. So from this slide, we can very clearly say streptokinase is less acceptable compared to other 3 agents. One of the biggest disadvantages of streptokinase is once it is given, we should not or cannot repeat it for 6 months. Some people say we cannot repeat it even for the whole life because allergic reaction will be more severe when you use second time, or it may not be as effective. Of this agent, so you can say the 3 new agents. So I don't know which agent I should favor, but in general, they are better than streptokinase because there is no immunogenicity. They act on plasminogen activation directly. They are fibrin specific, of which tenecteplase is more fibrin specifics. The plasma half-life is very important thing here. Tenecteplase is some advantage because long plasma half-life, so you can give as a bolus, and it can be given according to patient's weight. Another advantage is it's a plasminogen actor inhibitor resistant. That means it's less likely that it will be having resistance, and it acts almost much effectively compared to alteplase or reteplase. So you can say 80 times more effective as far as
last 1 minute, sir.
There's nothing more to say. So here, ease of administration of tenecplate is more. It can be given weight adjusted, and these are the plus minus advantages. So in short, I would consider tenecplate is probably better option. There are many trials which suggest that why it is better, and many hospitals abroad also is now follow this particular guidelines. So in this particular patient, I would say thrombolysis is preferred agent because of young age, stable patient, COVID fever already present, high pulmonary risk, and very risk to the high health worker. Amongst thrombolytic agents, because we definitely prefer fibrin specific, and amongst that probably tenecteplase we prefer because you can give a single bolus and it's more effective in this particular patient. So there are many points I will not go into detail because the time is going on, but I will just like to mention that patient outcome is more important than our income. Listen to the patient. If they say no, means say no. I had one patient who has required angioplasty. He said no. I did thrombolytic. After 3 days when I did angiography, it was left main and triple vessel disease. So this is what I have to say. Of course, this is I would like to tell everyone that my fear of doing angioplasty is now gone down, and I do angioplasty. So my final concluding slide is, if any of you have any patient who requires angioplasty and they are in Baroda, I am very much happy to do angioplasty with PP mask, even if I have to tell in favor of thrombolytic treatment at the moment. So I just conclude here.
Very nice presentation. Sir, we will invite questions only for 2 minutes. 3 questions.
Over to chairperson, please. Chairpersons. Gaurav Gandhi, Sanjay Bagani, Keval Kanabar, Jitendra Anand, Devangsha, Ronaksha. Your comments, quick comments. We'll start with Gaurav. Gaurav, your comments, please.
Yeah, so very nice presentations from all of three. And here there are 2 aspects are there. One is that if this patient would have been inferior LMI, very stable patients and without any failure signs, no any CCF, then obviously thrombolysis would be the treatment of choice. Here, this patient is extensive anterior LMI with Phillips class 2 failure. Large myocardial muscles are involved. So obviously primary PCI would be the best option. But here comes the second aspect, that how much fast we will be offering the primary PCI to this patient in COVID era, because obviously there are logistic problems and
Dr. Sanjay. Dr. Sanjay Bagani from Surat. Your comments, please. Dr. Keval. The network issues, I assume, with Dr. Gaurav.
The network issue, same issue as with PCI in many cases. That happens.
Dr. Jitendra Anand, Devang Bhai and Dr. Ronak Bhai both have been, treating a lot of COVID patients as COVID physicians. Yes.
Sir, one my question. Even in COVID ARDS patient, if we give heparin, then there is an increased incidence of hemoptysis. What about the after fibrinolysis? It may increase more, and it may be one of the major complication. And if it occurs, then we are stuck.
But see, in that case, we are stuck in both the situation. When you do angioplasty, you have to give upfront lot of heparin during angioplasty and sometime post PCI as well. On the other, if you use streptokinase, there is no need to give heparin afterwards. So that is one theoretical benefit of thrombolytic. But thrombolytic itself will increase chance of bleeding. So when patients corona and coronary together, we have it. We both are especially acute massive anterior MI and COVID positive with pneumonia, we are in big trouble.
I think Devang Bhai, your question is very valid. What you're trying to say, we had our own data from your own patients, Devang Bhai, which we published on D dimer as a predictor of outcomes in patients, whether you give TOSI or you don't give TOSI, apart from lytics versus no lytics. And I think it's not just the load of the thrombus burden per se, but D dimer, which is also reflective of the load of prothrombotic milieu that exists, is also a predictor of the outcome, as we all know. And tocilizumab actually had an impact on the D-dimer cutoffs in the outcome. So yeah, this is as Dr. V.C. Chauhan said, it's very complex. COVID with coronary is really something that probably we are still trying to comprehend. Dr. Ronak, your comments?
I think thrombolysis should be preferred or not. That's the only reason I want to ask. If in a remote areas where the cath lab facilities are very scanty, should we go ahead with the thrombolysis or not? Because there to diagnose COVID, in a suspected COVID, what to do?
See, if it is massive anti-MI like this, then you have to give thrombolytic in that particular scenario. And COVID itself is a high thrombotic milieu. So patient may have not only coronary, he may have extracoronary thrombotic milieu as well, where thrombolysis theoretical could have helped unless there is a massive intracranial hemorrhage risk as a risk. But where it is not possible to angioplasty, obviously there is an advantage of giving thrombolytic. On the other hand, when it is possible to do immediate angiography, many people, they do angiography and they realize that there was no block. It was myocarditis which mimicked like a ST elevation, where thrombolysis was a very big risk and harmful. But obviously then you don't need angioplasty as well. So diagnostic angiography in that situation makes a difference. But when you say there is no possibility available, obviously you have to go ahead and give it. Calculated risk has to be taken.
Okay, fine. I think in the interest of time, we have to stop here. And there are recent guidelines which have come from ACC, SCI, and the European Society on acute MI and COVID, which is a fantastic document which we all should read. 10 take points, and I think we have included some of those questions in the quiz which you can participate. Not you, of course, you are all specialists, but you can learn a couple of things from that quiz, and we have kept 15 winners for that quiz over the period of Cardiocon. Thank you. We should end this session here, and